Chapter 13 is disorders of red blood cells. When we talk about red blood cells, a key component in them is hemoglobin. This is what carries oxygen. It's made up of 2 alpha chains and 2 beta chains, and then they have an iron-containing group called heme, and oxygen is what binds to that heme. And of course, carrying oxygen to the tissues is the fundamental activity that red blood cells perform. Question: how many molecules of oxygen can be carried by 1 molecule of hemoglobin? And the answer is 4. Each hemoglobin molecule has 2 alpha and 2 beta protein chains. Each chain has 1 heme group, so each heme group, 4 chains equals 4 heme groups, is capable of carrying 1 molecule of oxygen, so a total of 4. Erythropoiesis means the making of red blood cells. And if we look at this, if there's decreased blood oxygen, let's say you've gone up to a higher altitude, for example, or you have chronic obstructive pulmonary disease, for some reason you're not getting as much oxygen into your system, kidneys will secrete erythropoietin, which will stimulate the bone marrow to create new red blood cells. They give you some questions here. Why would a man receiving chemotherapy for cancer develop anemia? So any kind of chemotherapy, anything that's treating cancer is treating cells that are rapidly growing, and so we could damage rapidly growing cells like the red blood cells that are forming. Also, if we damage our bone marrow is where we make red blood cells, so that could also be a possibility with chemotherapy. Why would a man with renal failure develop anemia? Well, renal failure, renal means kidney. Kidneys secrete erythropoietin. If the kidneys are failing, in addition to not forming urine, they're no longer secreting erythropoietin, so it would be the lack of erythropoietin, or EPO, would be a cause for anemia in someone with renal failure. So, red blood cells. How does this work? Bone marrow will create new ones. We can have immature red blood cells. As they become more mature, they still have a bit of their endoplasmic reticulum in them, causing them to be called reticulocytes. And these are seen in the blood stream, and that tells us whether our body is making more new red blood cells. They will continue to mature and lose that little bit of endoplasmic reticulum to become mature red blood cells as they get older. So red blood cells last for about 120 days. What causes them to wear out? Their membranes become weakened. They don't have a nucleus, so they don't have any DNA from which to make RNA with which to make new proteins to fix their membranes. And eventually they'll break as they squeeze through the capillaries, particularly in the spleen. So they circulate for about 120 days and then become damaged, and they are recycled. Most red blood cells break in the spleen. So break in capillaries in the spleen. They're eaten up by white blood cells in the spleen. And then we recycle all of their contents. So white blood cells living in the spleen are ready to process the red blood cells. We create unconjugated bilirubin. This unconjugated means it's not very water soluble. It needs to be conjugated in order to become water soluble so that the body can more readily get rid of it. And they offer you a question: why would a man with defective red blood cells develop hepatosplenomegaly? So hepato is liver and splen is spleen. So these are areas where red blood cells are broken down. So if this individual has defective red blood cells, they're going to be broken down to a greater extent, causing these organs to become bigger. This megaly means the organs have gotten larger. The fate of bilirubin. We have unconjugated bilirubin that's been formed when we break down the red blood cells after 120 days. And bilirubinemia means bilirubin in the bloodstream, leading to jaundice. If, on the other hand, we conjugate it, so liver links it to form conjugated bilirubin that we will release in the bile. So the question is, why would a man with liver failure develop jaundice? Because the liver is responsible for conjugating that bilirubin so that we can put it into the bile and get rid of it. If we don't have our liver working, we're over here and we get jaundice. when red blood cells are destroyed outside the spleen, well, what's going to happen then? Then the contents of the red blood cells are released into the blood. That's the hemoglobin. Hemoglobinemia means hemoglobin in the blood, and hemoglobinuria means hemoglobin in the urine. And so hemoglobinuria makes the urine cola colored, going to cause us to see that hemoglobin in the urine. Question, why was malaria called black water fever? So malaria causes the red blood cells to break down. Hemoglobin in the bloodstream will then be filtered out and be in the urine, causing the urine to take on this cola-colored quality. Let's see. Question. Red blood cells, erythrocytes, are made in the blank and destroyed in the blank. So we know from our previous slides they are made in the bone marrow and destroyed in the spleen. Erythropoietin made in the kidney stimulates the bone marrow to produce them. Eventually they break up in the spleen, and if you don't have a spleen, also broken up in the liver. So different types of anemia that we can have. Iron deficiency anemias. These cells are not as darkly colored. Megaloblastic anemia. We're having trouble with the DNA, and so this causes megaloblastic anemia. Sickle cell disease is a disorder where people who are homozygous for the sickle cell gene get a condition where their red blood cells will form these sickles under conditions of low oxygen. And then we have normal red blood cells for comparison purposes. Causes of anemia. So anemia is a lack of oxygen carrying blood ability in the blood. So blood loss would of course do that. Hemolysis means the red blood cells are being destroyed, or impaired red blood cell production. All three of those would cause anemia. So let's see what we have here. Severe anemia resulting in weakness, angina, fainting, tachycardia, sweating, and pallor, pain in his bones and sternum. So what is going to be caused by the decreased red blood cells and oxygen, and how is this individual going to try to compensate for it? So depending upon what sort of anemia you have, your compensation mechanism would be to make additional red blood cells. So if it was due to blood loss, you would try to make new red blood cells. It might be that the problem is aplastic anemia, and so there wouldn't be a way to make more new red blood cells. So anemias of deficient red blood cell production. These fall into categories of iron deficiency anemia, often caused by blood loss, particularly if we have internal bleeding that's going into the digestive tract. Megaloblastic anemia, so a lack of vitamin B12. That deficiency results in pernicious anemia. Folic acid deficiency also results in those megaloblastic anemias where we have trouble making DNA, making the nuclear contents for red blood cells. Aplastic anemia, bone marrow depression, and then chronic disease anemias. So when you have a chronic disease, you tend to have anemia, whether it's from chronic inflammation or chronic renal failure. So iron deficiency anemia. Hypochromic, this means they're not as brightly colored. Microcytic, so they're small erythrocytes with irregular shape and irregular size. B12 deficiency, pernicious anemia. Megaloblastic anemia. They might be large, but they have an oval shape, odd-shaped, teardrop-shaped, as well as neutrophils, which are a type of white blood cell, being hyper-segmented, more segments than you would normally expect to see. So, what do we have here? A boy presents with pallor, weakness, increased respiratory and heart rate, enlarged spleen and liver, yellow skin, dark brown urine, low blood cell count. So what's going on here? It sounds like he has a hemolytic anemia because we see dark brown urine. That tells us that he's got hemoglobin in his urine. Yellow skin is jaundice, so we're also getting unconjugated bilirubin that is overwhelming the system. Pallor, weakness, increased respiratory rate are all going to be due to the anemia itself. Which type of deficiency is caused by pernicious anemia? And it's going to be a B12 deficiency. So we have something called intrinsic factor that's made by parietal cells in the stomach that normally binds B12 and carries it and allows it to be taken up in the intestine. And in the absence of intrinsic factor, we cannot absorb B12, and we get a condition called pernicious anemia. So hemolytic anemia. Hemolytic means the blood is being destroyed. We can have membrane disorders, hereditary spherocytosis. So a sphere is a round ball shape, and that's not what the normal shape of the red blood cells is. Also acquired hemolytic anemias and hemolytic disease of the newborn. So if mom is Rh negative and the child is Rh positive, antibodies from the mother's immune system can destroy the baby's red blood cell. Then we've got hemoglobinopathies, sickle cell disease, and these two types of thalassemia, alpha and beta. Both of these conditions are helpful in areas where malaria is prevalent. If you're heterozygous for the gene that would cause this. If you're homozygous, it is problematic. And then we have something called G6PD deficiency, where we can, under conditions of stress, start having anemia develop. So we're looking at a diagram of sickle cell disease, mutation in the beta chains of hemoglobin. So when it's deoxygenated, they link together and form this shape of the cell that looks like a sickle. So deoxygenation is what is driving that process. So what problems are caused by sickle cell disease? Blocking capillaries, very painful. You cut off the blood supply to something, it starts dying, it's very painful. Infarction means death of the cells, so can cause chronic damage to liver, spleen, heart, kidneys, eyes, and bones. Pulmonary infarction, so infarction is death of the tissue due to a lack of blood flow, causing acute chest syndrome. Cerebral infarction, which is a stroke, and then sickled cells becoming destroyed, leading to jaundice, as we saw a few slides back with the unconjugated bilirubin building up. So sickle cell anemia inheritance. If we have an individual who has sickle cell trait, they would have one normal gene and one gene that would code for sickle cell. The wife has sickle cell disease, so we would get a gene from each of our parents. So from the wife, it would be inevitable that we would get the gene for sickle cell disease. From the man, it would be a 1 in 2 chance because one of his genes is codes for sickle cell and the other one does not. So 50% chance. So they talk about some additional things. In a population, the gene frequency of the sickle cell allele is 10%. And so what does that mean? Why would something that causes a problem be so common? And the answer, again, is that individuals with sickle cell trait have greater resistance to malaria. And so that's what they're talking about here, that this heterozygous essentially carrier of the disease exists in greater numbers because of their resistance to malaria. So tell whether the following statement is true or false. Patients with sickle cell anemia who also suffer from lung disease are more prone to sickling. So what did we see before? We said hypoxia, lowered oxygen results in this, and so true. Hypoxia, more likely to occur in lung or pulmonary disease, is an important exacerbating means makes things worse factor associated with increased sickling and vessel occlusion. Now we can talk about fetal hemoglobin. So it is special because it needs to be able to pull the oxygen from the placenta into the baby, away from mother's blood where the oxygen is being carried by mother's hemoglobin. So alpha chains and gamma chains, no beta chains. It was the beta chain that was malformed in sickle cell, or that had a substituted amino acid, so it cannot sickle. So some people that have fetal hemoglobin are partially protected from sickle cell disease. And now we talk about the thalassemias, alpha and beta. Alpha, defective gene for alpha chain synthesis. Beta, defective gene for beta chain synthesis. And again, may have 1 through 4 defective genes for alpha, 1 to 2 of beta. Affects both fetal and adult hemoglobin for alpha. Affects only adult hemoglobin in beta. So these are thalassemias, or another condition like sickle cell anemia where some resistance to malaria has caused this to be more common than we would expect. So if you have thalassemia, what kind of conditions might you expect yourself to have? Pale skin and gum, fatigue, headaches, treated with transfusion since childhood, enlarged jaw, 2 leg fractures, Heinz bodies, liver is enlarged, jaundice, and liver failure. So, which of these are signs and symptoms due to anemia, which to compensatory erythropoiesis, and which are due to the treatment? So, this is an interesting scenario. The Heinz bodies are from the transfusion treatment. The enlarged jaw and leg fractures are due to her overturn of increased production within the bone marrow of red blood cells. Pale skin, gums, fatigue, and headaches is due to the anemia itself. Then enlarged liver, jaundice, and liver failure. This is due to breakdown or hemolysis and the products from that resulting in jaundice.